Good evening, everyone. Thank you for joining. We'll start in just a minute. Well, we've hit the top of the hour, so let's start. Thank you very, very much again, everyone, for being there. This is another of the Academy of Nutritional Medicine's webinars. We're absolutely delighted to have Dr. Aylin Ozdemir and Kunal Garg together with us this evening. And she will be speaking about Lyme disease and neuro-recovery, Lyme disease, co-infections, and the brain, clinical strategies for neuropsychiatric and neurological recovery. And I'll just give her a very brief introduction, and for Kunal as well, but I'm sure that they're both familiar to you. Dr. Ozdemir gave a wonderful presentation on pandas and zebras not too long ago, and Kunal has been a regular speaker for us. Unfortunately, Professor actually, Leona Gilbert, was unable to join us today. So just to go to the screen I have here with your bio, Dr. Ozdemir. She is a leader in pediatrics and integrative and functional medicine, widely recognized for her pioneering evidence-based approaches to advanced medical care. She has served as the owner and medical director of Pediatric Associates of Jacksonville since 2001, and that's a legacy of pediatric practice originally founded in 1932, which she continues to guide. She completed her medical degree at the University of Istanbul and pursued postgraduate training at Queen Mary's Hospital for Children in the UK, and then undertook her pediatric residency at both the Children's Hospital of Philadelphia and Long Island College Hospital. And then, being dedicated to integrative medicine, she completed the prestigious Fellowship in Integrative Medicine at the University of Arizona under Dr. Andrew Weil from 2010 to 2012. And she has had many awards and also written scientific peer-reviewed articles in journals and contributed to many studies. So we'll be hearing more about that in a moment. And Kunal Garg is a biotechnology and nanoscience expert specializing in diagnostic solutions for infectious and chronic disease, and is the co-founder and shareholder of Tested, a Finland-based in vitro diagnostic manufacturing company. So Kunal, since I think you'll be starting, I'll leave you to add to your amazing bio. Thank you both very, very much. By the way, everyone, please put your questions and comments in the chat or the Q&A. We'll tap into both at the end. The talk will probably last about 40 to 45 minutes, and then we'll have time for questions at the end. And if you can't stay, if we do overrun a little bit, then it will go up on past webinars on the aonm.org website just a few days afterwards, both the recording and the slides. So thank you very, very much and look forward.
Great. Thank you everyone for joining, and thank you, Gillian, for the intro. So I know everyone is here for the case studies with Dr. Aylin, but I'll just take 5 minutes on the clock to just give you all an idea of how we came about to be over here with all the case studies from Dr. Aylin's clinic. So I will just run you through the procedures and the guidelines that we had followed for putting these case studies together, and some exciting things that we are doing in September this year, actually. So next slide.
Oh, we're missing your slides.
Oh, okay, no worries. So what we've essentially done is that we've followed the CARE guidelines. So CARE guidelines are the guidelines used for writing case studies. And we've done that over the last 2 years with Dr. Aylin. We worked on 25 cases in total, but we've only managed to publish 9 at the moment. So there's a few more to go, so to say. And we've worked on Lyme, neuroborreliosis, neuropsychiatry, stealth infections, and a lot of that will be coming up today in the case studies. But one important thing that we've done this, and the reason why we've done this is because publishing case studies or case reports is very important. Without these, the literature does not get filled with actually the real world evidence of what kind of patients are usually being seen in clinics. And that is why if you're a doctor, if you're a scientist, and if you work in this area, it's just basically encouraging you to actually get this done. One of the other facts that AONM can also send you an email about later on is that we are organizing a conference in September in Turkey with Dr. Aylin's help to get such scientists and doctors on the same platform and also patients to actually present their data. So if you're interested, you can check us out at chronicinfectionpathologies.com. So that's www.chronicinfectionpathologies.com. And you'll find more such case studies and even a lot more case studies that we've not yet published at the conference. It's a hybrid conference, so you can either attend it in person or virtually. But with that, I leave the stage to Dr. Aylin. Thank you.
Thank you so much. And thank you having me again, AONM. And this is a big year for me because many years ago when my family was stricken by Lyme disease and co-infections, and I said, I think I'm going to just have the information one day and I just want to go back to the roots where we all contracted this disease in Eastern Europe. And I'm going to just scream on top of the mountains with the information. And the conference in September with the chronic infection pathologies group is, to me, is bringing everything to full circle. And I'm grateful for the opportunity even here and sharing this information with the global audience. So what is neuro-Lyme and Lyme borreliosis? I am going to break down the pathophysiology, physiology, mostly pathology, and then difference in immune system reactions. And then I want to just leave kind of more time to discussions in the end, because we've got 10 cases, just a correction to Kunal, we actually published 10 cases. I'm sharing 10 more cases here. Some of them are published, some of them are on their way to getting published. So I will not share details of some of them, but we will just put the information out there to kind of learn from our outcomes. So sudden encephalitic-like onset of neurological symptoms is pretty much constellation of neurological involvement of neuroborreliosis. And lymphocytes are the main player in the meningeal tissue. And cranial neuropathies, mainly facial palsy. In radicular neuropathies like the neck pain and cranial cephalgias and radiculopathy pains, that could be the hallmarks of initial presentation. Encephalomyelitis present with subtle encephalopathy with sometimes cognitive behavioral neurological symptoms. I include this in also patients present to us with demyelinating polyneuropathies and small fiber neuropathies. Currently, a conventional approach does not involve the Lyme disease part of their initial workup, but it should be always included, in my opinion. And medical history and physical exam in the conventional approach always stresses out the early detection. So if you suspect, we need to early detect. But the early detection, what's stressing out a plausible evidence of a tick bite, meaning that we need to know the patient is in hyperendemic area. We need to know there's a tick bite. And then there are constellation of symptoms, then aha moment to go order proper testing. But after thoroughly examining our patient's medical history and then next steps of neuroborreliosis testing and diagnosing, including our integrative tools over the last 25 plus years, and it's very evident to us that and the constellation symptoms according to the conventional data doesn't follow the rules for diagnosis early diagnosis and efficient treatment and remediation of cancellation of neurological complications. So, and lymphocytic meningitis and Bell's palsy, radiculoneuritis, these are the hallmarks, and it would be easy. And with the plausible exposure, tick bite would be, okay, bingo. But unfortunately, the 10 cases I will present at the end of these basic data doesn't follow those rules. And then serum antibody testing using the 2-tier markers, Western blot, and then is recommended over the PCR and culture in the spinal fluid. In the spinal fluid, always lymphocyte paleocytosis over the neutrophils. And epidemiology context is also very stressed out. And then routine testing is discouraged if somebody comes with the neurological symptoms, unless they have the constellation of symptoms and the plausible exposure to tick bite. At that point, unfortunately, too late for these patients, and we will discuss. And then cognitive neurological behavior symptoms of neuroborreliosis, and often missed in the conventional setting. That's what I'm trying to stress in this presentation, because, and then they are looking for peripheral neurological symptoms, but the plausible evidence to tick bite, positive serum antibody testing, or if there is a central nervous system involvement, intrathecal antibody produced by the Lyme Borrelia, which often tricks the immune system, one of the biggest trickster of infectious diseases. So then all of a sudden, these guidelines are falling short. And every single patient I will present at the end of this basic data came to us after 4 to 15 years of being ill. So then other thing is conventional realm stresses pathognomonic Lyme triad. So this is kind of almost like if the patient has EM rash and a Bell's palsy, oligoarthritic migratory joint pain, rheumatologic symptoms, aha, like another aha moment. And then as the Lyme triad, think of Lyme disease. But unfortunately, patients doesn't follow these rules. And the CDC, of course, emphasizes early diagnosis and management of these illnesses so important in order to prevent long-term sequelae. However, currently, we don't have a good serological lab criteria in our hands, and to just bring these patients to early detection, treatment, diagnosis, and recover them from debilitating chronic infections. So then, and then now that we're talking about permanent nerve damage, is part of the open evidence data when I was preparing these slides and look at all the data out there in the conventional setting. And then, Borrelia adhering to neurons and glial cells and Schwann cells, and then creates and often hides a cell from the galactocerbicide receptors, and then to induce the immune system. When it attached the galactocerbicide receptors and the myelin and in injury, it especially causes damage to the dorsal root ganglia. And that's a sensitive topic because many patients with dorsal root ganglia has a lot of sensory presentations, and then they get a lot of psychiatric diagnoses like, I can't feel part of my face and I don't feel my toes. I feel like my toes are burning in pain. And a lot of dorsal root ganglia symptoms often gets overlooked in neuro-Lyme. And then another thing is an infection is there hiding itself from the immune system. And then, but the byproducts are the infection system is there, and infection triggered inflammatory response causes further damage for these patients. And that's the reason over the years I developed a multidisciplinary approach, integrative approach to neuroinflammatory recovery, because as we get rid of the infection, we still have to deal with the immune system's dysregulation. And these are usually characterized by those IL-6, IL-8, and cytokine, and the paleocytosis and central nervous system, and then spinal fluids, and the leptomeningeal symptoms, vasculitis, sometimes endocarditis, and demyelinating neuropathies, and these could be the symptoms. Again, if we could diagnose early, and then CDC and all the conventional data stresses early treatment with antibiotics from the irreversible axonal loss. So then chronic and severe inflammation results and neuronal glial apoptosis, axonal degeneration, demyelination, and irreversible symptoms. And then one other thing is about Borrelia. Even though a non-viable peptidoglycan component of the Borrelia extremely neuroinflammatory, and that kind of almost like creates a havoc in the central nervous system. And it just wants to just kind of almost put out the fire, but along the side, in a lot of apoptosis and pro-inflammatory properties of the peptidoglycans causes permanent nerve damage. But with the integrative approach, and I'll see how we can show you that we reverse a lot of cases in our patient cohort. And then now neuroborreliosis leads to permanent nerve damage is related to some certain clinical signs and symptoms. So then those are patchy asymmetric sensory loss and touch and vibration sense changes, diminished tendon reflexes, and a lot of burning and tingling, stabbing, and none of the conventional protocols actually pinpoint chronic Lyme disease aftermath for these patients. And then that's the reason a lot of patients in our cohort had averaging 4 to 15 years before ailments and then suffering before they came to see us. And then one other thing is very important differentiation between ataxia with the dysarthria and nystagmus could be maybe early Parkinson's, but without the dysarthria and nystagmus always points out to the dorsal root ganglia symptoms, sensory ataxia. Differentiation, there's two findings is so important so we can say, okay, this is not probably Parkinson, there's something else going on with this patient, so they don't get this basket diagnosis, immediately go to the conventional route. We have to think out of the box for these patients because even slight changes in their clinical presentation and a physical exam, and then might make the practitioner question, let me just think about infections, plural, induced encephalopathies, what is causing all the constellation of symptoms? Because often these patients have chronic fatigue syndromes, arrhythmias, gastric dysmotility, sweating disturbances, and POTS, dysautonomia, pain syndromes, and impaired swallowing. It's often interpreted as psychiatric symptom, anxiety, and then they also often get diagnosed gastroparesis and dysmotility syndromes. So laboratory workup, and currently what we have, the two-tier testing, but in terms of when it comes to neuroinflammation, and I think we all know, viral, parasitic, cysticercosis, and some other infections can cause a significant neuroinflammation that should be included in the workup, including COVID and SARS-2, and what we are observing within the last 5+ years, and long COVID, and a lot of inflammatory markers are triggered in the central nervous system for this patient. So this is our basic conventional workup, and then nanotechnologies we use from the specialty labs for urine nanotrap labs, and then from Galaxy Labs, I have to give them credit for it in the PCR assays and things like that. But when we just look at the conventional data, they're often discouraged not to use PCR for the neuro-Lyme as a first line. And again, back to the conventional criteria shortcoming. And then an autoimmune and markers like Cunningham panel, formerly called Cunningham, currently molecular labs. Autoimmune encephalopathies also detects an autoimmune nature of the aftermath of the neurological disturbance. And then also in my PANDAS presentation, I got more in the detail of quinolinic and carnic acid ratios and how they present as a special quinolinic acid as a neurotoxic marker. And then, of course, imaging studies for central nervous system, EMGs, EEGs, echocardiogram, EKGs, and a sleep study is important for these patients. And then integrative medicine, and we also add some environmental testing and toxins, toxic exposures, urinary organic acids, their mitochondrial functions. And a couple of patients actually in our patient cohort came very suspicious of Lyme disease, but then one of them actually had mitochondrial disorder, congenital. So then with that really ruling out congenital mitochondrial disorder, if we just call everybody Lyme, we would be also missing some other pathology might be in the picture. So then adding that urine organic acids, doing serum amino acids and urine pyroluria testing, rule out other chemical pathology which can present with neurological illnesses. And the methylation system is so important to be supported because it was one of our actually very first early days in my integrative medicine practice, and helps to kind of repair that DNA, oxidative stress, and understanding the methylation pathways, also very important. Other oxidative stress markers that we monitor and routinely check is 8-OHDG and lipid peroxidase, and very important markers to see if the infection is causing oxidative stress, and we need to manage oxidative stress along with getting rid of the infection and clean the aftermath after the infection. Those are the simple principles of my integrative approach for neuro recovery. And then zonulin and gut integrity. As we all know, early days of my helping my autistic patients back in the years, we know that, for example, C. diff and can cause disruption, but the same toxin from C. diff can cause a lot of neuroatypical behavior. So understanding what's overgrowing in the gut and cleaning that space so we can properly decode the neurotransmitters, and it's definitely part of our approach. And also histamine levels and MCAS and SIRS markers, understanding patient chemical sensitivities and decreasing those, so important in order to help their neuro recovery. One other very important thing, patients often come and central nervous system hormone disruptions. They've got primary disruption of the hormone system, or secondary adrenal insufficiency, secondary ovarian failure, thyroid dysfunction. And in these infections doesn't stay in one place, it's affecting multiple organ system. Without checking which organ is in check or out of balance, we wouldn't just be taking our big guns and antibiotics and expect patient to recover from the full aftermath of that infection, inflammation, cascade reactions. And I am not going to get into details of colonic acid, but it's an inescapable neurotoxin, and it's acting as a double-edged sword because we know that colonic acid is kind of all your first line defenses, especially, and the microglia get stimulated by macrophages. It just produces colonic acid to make NAD to just try to repair itself. But once this mechanism is broken, and then colonic acid is almost like a little avalanche coming, and it instead of opening in more mitochondrial function pathways, it opens the blood-brain barrier and it causes secondary demise, almost double-edged sword. And there's urinary colonic acid levels we also monitor to understand neuroinflammation in patients. And not only infection, we know that inflammation and then some other neurological disorders can also impact the colonic acid levels. So infection is not the only trigger. And there are some endogenous and exogenous reasons for that. And years ago, I had a very interesting call from one of the centers, probably 10, 15 years ago. And I said, I have this SPECT scan for a patient you sent for investigation, and what looks like a traumatic brain injury. As a matter of fact, tick-borne illness and traumatic brain injury in the SPECT scans looks identical. And that was I think that was the very first case, more than 10 years ago. And then kind of made the imaging center just get more into the Lyme field, which is very good. So then quinolic acid and infections and heavy metals, neurotoxin, mycotoxins, and then stealth viral burden. As we know, bacteria comes, we treat, goes away, but the viruses stays within the organic body, and that's how viruses behave. If you're exposed to, EBV, it's going to go dormant. HHV6 or 3 days measles, roseola, we have it early childhood, it will go dormant. But when the immune system is suppressed with the infection, these viruses get reactivated. It's very important to understand their role when we are dealing with the multifactorial illness or traumatic brain injury. One of our patients went to amusement park and came back entire flavor Lyme disease from the whiplash, and blood-brain barrier opens up and allows this infection go in the central nervous system. And the treatment and outcome is never linear. We have to think multifactorially. And then this is a little diagram for everyone on their own time to study. And as one of my favorite ones, I'm not going to get into details for sake of time. And then there are a lot of cell types in the central nervous system and immune system, and how the monocyte macrophages microglial cell gets stimulated and by the infection inflammation. And I just wanted to just put this out there because without understanding the cell function, physiology, and pathophysiology, just what we all learn in basic science and pre-med, it's very difficult to understand the such chronic nature of these illnesses, how we can bring it back to the functional astrocytes and oligodendrocytes. How do we just decrease the gliotoxin and, for example, toxicity damage from the central nervous system? Once we understand the physiology, I think it's reversible. And blood-brain barrier, it's very important to understand them, endothelial cells, and then even heart muscle, connection of the heart to the brain, and the vagus nerve, how the nerve shafts are providing like a highway track for the infection to communicate from heart to brain, brain to heart, and then gut to brain, brain to gut. Without understanding these steps, we couldn't just understand how to undo the damage. So then, and all the molecular compounds can be looked at. Some of them are biomarker we can detect. Some of them are educational purposes to understand the pathophysiology, so we think as we approach every single case. And that's another molecular bioscience testing and autoimmune markers in the brain and post-infectious autoimmune encephalopathies, so that we can just look at before and after markers to see if things are going the right direction. And this is one of our other favorite slides, and I think everyone just download and share a copy of this. Understanding how every natural micronutrient and the mechanism of action, and how we can actually naturally support the body to reverse the damage happening from kind of multifactorial havoc from the not only infection, also inflammation. And then in certain diseases, and what are the quin levels, and then what are the associated alterations in chemical pathways is in the slide, very helpful. And then I'm going to bypass this, so in sake of this discussion of the cases, so we have enough time for questions. And this is a 21-year-old female. We're in the process of actually getting this ready for case series publication. So I'm not going to just give all the details of this case, but then I'll give you the hallmarks of it. And she came to see us around 21 years of age, and 6 since 8 years of age, and over a decade illness. And she was dragging her feet and couldn't walk, couldn't stand up without feeling dizzy and faint. And chronic nausea and gastroparesis, and then chronic fatigue syndrome. She would eat something and then throw up 2 days later what she ate for lunch 2 days ago. And then all of these was contributed to in a Midwest Medical Center to anorexia nervosa. And then she was referred to psychiatry and multidisciplinary anorexia treatment. When she came to see us and her EMG was abnormal, she's diagnosed with chronic inflammatory demyelinating polyneuropathy, POTS, gastroparesis, and myalgic encephalitis, and just the old name, chronic fatigue syndrome. And then what really brought her to us was after COVID, and she had very complicated, exaggerated symptoms. So at that point, family was thinking something is getting missed here, and the COVID made her symptoms much worse. Could this be infectious? So none of the tests were positive in the United States. We had to send a specimen across the pond to Finland, and this is tested labs findings. We treated her with the multidisciplinary approach. And for CIDP, she is on immunomodulator dose of IVIG, and immediately start walking with no pain. She start walking, she start gently hiking again. And she is on the mend, but she kind of lost to a lot of childhood, but she is a happy ending. So I'm going to present my next case. And then this is a neuroatypical child, and then many years of cognitive, developmental, educational difficulties, along with chronic common variable immune deficiency, chronic immune deficiency diagnosis, diagnosed with PANDAS around 12, and then treated over the years with the full recovery from Lyme disease and co-infections. After 2021 COVID exposure, this patient's symptoms re-emerged with like a tenfolds. And then in the end, not only she was treated for spike protein load and also mold exposure along the way, we also found Toxoplasma gondii in this patient. So then I think this was the missing link. What I'm trying to point out in this case, if you're not testing, you won't know. So then Toxoplasma, like, wait a minute, we're scratching our heads. Everything is treated. What is left? In her case was Toxoplasma and the mold toxicity. And then everything kind of almost like was teetering on the brink. But what really pushed everything over the edge in my clinical observation was a COVID illness. She's supported with IV nutritional therapy, spike protein protocol that we use in our clinic. Involves a lot of IV anti-inflammatory infusions. And then also liver detox and neurological cocktails of infusion materials. And then she is currently doing really, really well, quite mainstreamed. And I have to give credit to also Armin Labs for the Toxoplasma gondii positive test results, because our test results in the United States were negative. And then this was her post-treatment results and the positive SARS-CoV markers from tested labs. And this is one of my favorite cases, 52-year-old female. She was taking care of two neuroatypical children, one very complex, one, and I'll discuss down the slides. She came with I can't remember any of the instructions that you're giving me. Like, I can't remember. I just can't put my brain around it. I thought she's overwhelmed mom. And I said, tell me about your background. And then when we found out that she grew up in the bushes, multiple tick bites, so I said, why don't we test you and send your specimen to across the pond as well, since you are negative in the United States. The Albert is negative. And then those are the results. And she had the EBV positive IgG, and she has evidence of Lyme disease and persister forms. And when I saw that European, obviously some of the different strains turned positive, then I found that actually this family is from Europe, and then an exposure was in Sweden. So I said to her, I think we need to take care of you first, so before we can take care of your children. She goes, I will never take a dose of antibiotic. And I'm like, okay. So then I just have to be creative here. So we came to an agreement that we'll develop our own protocol for methylene blue, and which we did, and we volume-based calculated 1% solution of human consumption grade methylene blue and treated her with methylene blue. But what's very, to me, I find it interesting in this case was right before we start treatment, she goes, I have another symptom. I've got cystitis, frequent urination. I just kind of, does Lyme cause that? I said, it might, but we have to do a urine culture for you before we assume it. She was positive for over 100,000 E. coli, gram-negative UTI. I go like, I think like that requires antibiotic. I just don't feel comfortable like letting E. coli UTI not treated with that antibiotic, and then cause a urosepsis. And that's kind of, to me, is a little bit just like too out of my comfort zone. Then she goes, no. Okay. So then I said, I think you should talk to your primary care physician. I'm the specialist here. Let's just define the like nice boundary here. She didn't listen to me, but she took the methylene blue protocol, and for a total of 6 weeks. And in the middle of that protocol, 2 weeks mark, she came back. She said, my UTI symptoms went away. Can you please culture my urine again? And then I did not take one single dose of antibiotic. 2 weeks on our methylene blue protocol, E. coli over 100,000 urinary tract infection marker was negative. Her E. coli UTI fully cleared and her symptoms went away. We finished 6 weeks protocol. And after 6 weeks and the left lower corner of her results, her antibodies calmed down as well. And I think we had a very positive outcome. And then she is 100% recovered from this, almost like a short-term memory and brain fog symptoms. And this is another case, and an early onset Parkinson's disease patient. It's one of my favorite patients, but I'll have to just kind of speed up here. She came to see me 10 years ago, would not believe in Lyme disease. And when they recommended that she gets transcranial intervention for Parkinson treatment, she ordered herself a mail order test for home testing. It came positive. Then a confirmation from specialty labs, IGeneX was also positive. So this was a positive Lyme disease patient, came to see me back 10 years later, now a believer that Lyme disease can cause early onset Parkinson. And then all her symptoms went downhill after COVID, and then Parkinson was like rapidly progressing to go to the final stages of the illness. So we treated her with the antivirals for calm down her EBV antibodies. We did the spike protein protocol for her. We also treated her for Lyme disease, and she had also Bartonella as a co-infection. They were positive in the United States labs, and then she got treated. And after being told she was horizontal and she couldn't walk on her own, and she couldn't go out, dine, feed herself. And then after 6 months of treatment, that's the first year she did Christmas on her own. She refused any help. She's still thriving. And this is now is like, this is like 3 years fast forward for 54-year-old, still has tremors, still has some gait disturbances, but able to go eat outside without spilling anything on herself. And she's functioning. She's able to change her bed sheets. She's able to blow dry her hair. She had almost, I would say, 75% recovery, and she is very stable and not progressing further. And we are still supporting her. 44-year-old male with severe neuropathy pain. And this patient was very suicidal. And then this is the hallmarks in an infected tooth and Bartonella case. And then when we got the infected tooth pulled and Bartonella got treated, all his markers were positive in tested labs. Compared to all negative markers in the United States, was missed by a major tertiary care center over 4 years, diagnosed with all pain augmentation syndrome, meaning it's all in your head. And currently this man is thriving, 47-year-old, and incredible outcome. And we recovered him fully from his neuropathy and just doing really well. And another low-grade encephalitis, 55-year-old male with diplopia. And this case is actually, the reason I picked this case to point out, and spinal fluid didn't show any antibodies in this case. The second test result here is actually spinal fluid specimen. But the serum antibodies were positive. Never remember the tick bite, but remember the summer flu when they visited Norway 8 years prior. After that, he developed polyarthropathy and severe depression chronic sinus infection. He was getting steroid injections to all his joints, and then all of a sudden he started having vision problems, diplopia, and he couldn't drive anymore. And after Lyme disease support treatment, his diplopia improved, and he's still trying to fully recover from central nervous system infection. But this is a case that, spinal fluid may not have it. This patient has a neuro-Lyme, and that's the point I'm trying to make here. And this is a 23-year-old female with vision loss. One of my favorite cases. I have to give credit to Dr. Kenneth Linkner on this one. We co-managed this patient together. She came for a regular checkup for me. I'm her primary care physician, and she said to me that morning during physical, I have to turn my head right or left. I cannot see the sides of my head. Then during neurological exam, I diagnosed her with, she lost her peripheral vision. I was like, oh my gosh. Like, I remember, you were treated for Lyme disease. Let's see what's happening here. So then we tested for Bartonella. She had positive Bartonella and received the IV antibiotics and very complex treatment with the ophthalmology and multiple care providers. Her vision came back within literally a 3 months period and fully recovered. And she got married, have children. She's doing phenomenally well now. No more chronic fatigue syndrome or myalgic encephalitis. And then this is 25-year-old male. And that's actually came from a very complex tertiary care center with diagnosis of long axonal neuropathy, a permanent nerve damage from alcoholism, and was positive for Babesia and Lyme. Tested labs negative in the United States, and we treated this patient with the multidisciplinary approach. And then he was told that he'll be wheelchair bound rest of his life. And then not only he recovered fully, he's working in his very demanding job and require a lot of muscle power. And then 52-year-old male with headaches and severe neuropathy and just major sleep disorder, this patient. And he came to us because he was sent from, again, complex tertiary care center. We have one very big one here in Jacksonville, Florida. And headaches, he couldn't smell anymore after the COVID vaccine. I put this case in here. He said, after COVID vaccine, I can't smell. And I mean, not able to smell, anosmia is a symptom of a central nervous system involvement. Somebody lost smell, that means olfactory nerve is not working. It's by itself is an involvement of a central nervous system. So then, but he also had peripheral neuropathy. Back in the day, 3 years ago, I mean, we weren't just focused on peripheral neuropathy for post-COVID or long COVID cases, but I am very well aware of my Lyme patients having these symptoms. I'm scratching my head. I said, tell me, where did you live? Where did you kind of spend most of the time? He lived in a bunker in Maine and tons of tick bites, and then headaches and chronic sinus infections and chronic depression. So we treat this patient. He was actually CDC positive when we tested him. It was never tested. And if they did test him, he would be found. So, and we treat him for Lyme disease and Bartonella. He did very complex IV nutritional therapy. He is doing very well and thriving. And our last patient is a severe headache. And this patient was positive for cysticercosis along with the Lyme exposure. She's from Long Island. And everything came to a big, havoc of symptoms, after COVID exposure. And she lived 3 years of her life in their early teen years under the covers, dark room, was diagnosed with severe migraines, not responding to anything, didn't respond to any antiparasitic treatments after we treat her for central nervous system involvement, Lyme disease, and post-Lyme inflammation. And with the integrative approach, she fully recovered. She threw a big bar mitzvah party, and then we are very happy that she is now in high school and thriving well. Thank you so much. And this concludes my last case. And I'd love to have your questions and discuss further to learn from each other.
Thank you very, very much, Dr. Ozdemir. I'm not sure whether
Thank you.
you're able
And
to
stop sharing.
pull down the slides so that we can
I-
all see each other. Please do join us as well, Dr. Karg.
Yes.
Fantastic.
Thank
Thank you. Before going on to the questions, I just wanted to ask, it looks very much from your slides, Dr. Ozdemir, as though you almost have firm evidence there that SARS-CoV-2 can reactivate Lyme. I know that there have been a few studies on that, not a lot yet worldwide, but would you say that that's a definite conclusion?
Any infection, not just SARS. Any infection, like it's not, I'm not talking about common cold, but then we also see that patients like subclinical stealth infection, they have mono, all of a sudden everything comes to surface. And then SARS protein, it's intricate complexity of the spike protein. It's one of the biggest ones now. And even before the cases were published, we were just collecting this data, working and supporting our patients. We knew from the clinical outcomes. I'm a clinician more than a researcher.
Right. No, but it just looked so clearly because you had the red sort of SARS-CoV-2, also the IgA for SARS-CoV, so often positive. One other question, it's burning on, my tongue, so I'll ask it before I go on to the questions. You said in several cases that you treated them for the spike protein load and that was one of your specialties. Can you give us a few tips of what you do? Because that's one of the most commonly asked questions amongst us here in the UK.
I mean, and then just a disclaimer, I don't think there's one protocol out there to just claim the fame and anybody can go promote their approach is on kind of a social platform, and I am not doing that here. And with the same token, and I'll share my clinical experience. And when the SARS-2 IgG spike antibodies were first available, we were able to order them. Back in the day, we were able to get results up to 30, 40,000 count. Then it just was like, then some of them were like only 100 or 80. And then threshold for the SARS spike protein antibody marker 0.2, like 0 point. So we were getting 35,000. So for the last 2 years or so, the labs quit reporting anything over 2,500. So for me, it was a huge marker to see the difference between spike protein titer 35, 40,000 versus somebody only 500. So we were able to monitor that antibody levels. Currently, I'm using 1,000 as a threshold, and I can clinically correlate from my own clinical outcome because I see patients all day, every day. And then if anybody is immune to vaccine versus somebody is a spike protein like load, we can tell clinically. And then once we use them, mostly I use botanical, either oral or IV protocols. And of course, high dose vitamin C and an enzymatic approach, lumbrokinase or peptase. But then also we have to be very careful not to use the enzymatic approach too aggressively. And there are quite a few data out there. If we actually too much disrupt the biofilm enzymatic approach and these phages and then lining of the GI tract and carrying spike protein load may open up with the enzymatic approach and it actually can create more damage to central nervous system. It's very important to be very careful with that.
Yeah. Well, fantastic. Thank you very much. Well, I'll go to a question or several actually in the Q&A to start with. Dr. Flatabo asks, since Borrelia species are different from different parts of the world, as you discussed, for example, patient 3, you talked about exposure in Sweden. Sorry, I've just lost the question. To what extent do you feel that treatment is applicable to all Borrelia species? Is it important to be looking, for example, at Borrelia miyamotoi, which you didn't mention in your presentation, or do you feel that there's cross-reactivity amongst the different both testing types and species, so that your therapy will basically, as long as you've got the type of pathogen correct, that it will be addressed?
That is correct. But also you need to clinically correlate. If the patient is much sicker, and then we might even send a specimen to NIH or Stony Brook labs. And in some of these different labs may have different criteria or more research bandwidth. But in our clinical patients, 10 years sick come in, and then there are certain strains involved. It's a good question. Of course, the many species should be considered, but the clinical correlation is the key.
Okay, thank you. And there are quite a few questions here asking about the variety of medical, supplemental, or herbal protocols that you've used. I'll just read this one here. What are the medicines that you used? Were they all antibiotics, or did you use other treatments such as a herbal protocol? I think you've already mentioned that you used botanicals a lot.
Okay, so then any botanical cases that we monitored, collect data, and publish is available open access and in PubMed. And they can actually search under my name. Our protocols are available there. Mm-hmm. And then, but in terms of, we don't use antibiotics by itself or botanicals by itself. And there is not really one protocol would fit everyone. Understanding that individuality in picking the botanicals, antibiotics, or when to pick what, it's very patient specific.
Absolutely, yes. That's a brilliant tip. Maybe, I don't know whether you're able to, Haley, you could pop in just that 2025 article of Dr. Ozdemir's, just as an example, maybe as a link. Yes, Nava writes here, my clinical experience is that with many MS and Parkinson's cases who come to me with established symptoms, even when the labs come back normal, they're still experiencing spasms or palsy. You find that too? So you don't just go by the labs, of course, you go by the clinical.
I mean, the true question here is actually what to do if the tests are all negative. And then that's why there's not one single lab that we use. We still search. It's very important, even if you don't find one test positive, and then understanding the multifactorial nature. It could be like in our Parkinson patient, mono was reactivated and she was having recurrent sore throats and swollen glands. And then some of our patients, like they have recurrent like rashes, their strep constantly gets reactivated. They've got little typical scaly, sandpaper rash. They look at their ASO titers off the chart. Like, it's very important to understand the multifactorial, not just focus on Lyme, and don't forget like so many different strains and co-infections there playing a role. When the immune system, I think one thing in one of the slides said it, immune system chaos. Like once that happened, and there's the amylase in the brain and synovial tissue, that enzyme it doesn't have activity as much as blood system. So it doesn't really just go, makes it anti-inflammatory functions that actively, like it's happening in the circulation of blood. And other thing is Lyme spirochete cell membrane deficient. It doesn't follow the gram-positive, gram-negative bacteria. And so then peptidoglycans or the cell membrane itself, it just changes polymorphic forms. It might be not in the central nervous system. It could be in the bloodstream, or when it's not in the bloodstream, it could be hiding in the organ. So then something is so polymorphic, multiple forms of an infection, and then hiding in a tissue level. More spike protein burden is also in the tissue more than the blood.
Spike protein, the persistent
same thing.
form.
So then looking at a serological marker in the blood for something like this falls short. And therefore, sometimes we just provoke with the IV botanicals. And all of a sudden, like patient spikes a fever during infusion, and you know that you just like push something from somewhere, and all of a sudden within 3 to 6 weeks period, we get antibody results, like even like slight positive. So you know they're actively fighting. So like another thing is when you test, let's say this borderline, that we see that a lot with Bartonella patients because it hides in the nervous system. Borderline, then we treat and we repeat it 6 weeks later. All of a sudden titers goes up, and it indicates an active infection. It doesn't mean it's getting worse. Immune system is fighting. So, and monitoring the titers is also important if you find them.
Right, thank you. Suzanne is asking whether you think that it is possible to use herbal compounds for Lyme and co-infections. And of course, you have mentioned in your cases, like that one patient who said, I will not take antibiotics, that it was possible. Do you think yourself that it is possible to recover from these infections fully without antibiotics?
And depends on the patient. In this patient case, we actually published her cases in my publication. And then the volume-based methylene blue calculation is very simple, and it's open access. And in terms of, and if somebody comes with tick bite, bullseye rash, an early case of Lyme disease, there's nothing more nothing stronger than antibiotics for that stage. Waiting that patient to be treated botanically, to me, it's not following what we have collectively, not just an integrative approach, but conventional. Collectively, we all know more. And it's just not, we're not anti this or anti that. But then I'll tell you what I'm anti, and I'll be very clear with that. If a patient comes in a young age, when the brain is developing stages of a brain of a pediatric patient in developing. So then what are the fast developing stages of the neurodevelopment? Fetal, like post-conception, intrauterine, mom passing down Lyme disease to their child. If that mom is a Lyme disease active patient, she should be treated with antibiotics. There's no study that proven that botanical approach will decrease the transmission to maternal fetal, vertical transmission. So that would be, to me, not a good practice. And second thing is fast growth brain, 0 to 2. First 2 years of our children's life, then we are having fast neurological growth. And then puberty. Those are the fast growth stages of the life. And then we get this parents, and then like, oh, my child regressed. And then, and then vaccines are given in the United States around right before 7th grade, around 12 years of age. We get like neuroinflammation. Rather than saying that vaccine causes encephalopathy, which there are good, bad, and uglies, we all demand cleaner vaccines. But then my point is, anybody who observed a kid like this, rather than giving botanical protocol, must test that teenager early on for Lyme disease and co-infections. That is a clue. Your immune system in chaos had an inappropriate response to vaccine. And there is another player in the background, and that's your clue to test and treat that, rather than that is caused by vaccine. That's a huge, like, big topic in pediatric medicine, creates so much, I would say, smoke screen. But we can't just go with botanical, get rid of the smoke when the fire is smoldering. And antibiotics, in my opinion, is a must in the fastest growing stages of biological development.
Okay, to get rid of it faster.
Yes.
Understand. Thank you. A doctor here asks, what binds and neutralizes quinolinic acid, which you spent quite a lot of time discussing. Very, very interesting. She asks,
Yes.
does red light therapy help with that, for example?
Okay, red helps the circulation because improves the microcirculation. So then when the microcirculation improves, then NO, nitric oxide, comes to the microcirculation. Nitric oxide will decrease the oxidative stress. However, and the biggest gun that we have to wash out the cholinergic acid is definitely GABA and any GABAergic botanicals. And I gave the list in my presentation. And I love saffron. And then anything GABA promoting. And then I would recommend that along with the red light therapy. It wouldn't hurt.
Okay, thank you. What age range do you treat? One doctor here asks, is there any, do you treat children as well? You obviously do, because you've talked about.
I treat every age and group, and I treat all ages. And my oldest is 97.
Oh, wow.
And of course, I treat pregnant moms, and pretty much it makes a full circle.
Yeah. Do you mentor, by the way? Is there any opportunity for anyone to sort of attend a mentoring group with you, a bit like sort of Nancy O'Hara does, for example, or are you too busy seeing patients on?
No, and there are some new things is that we'll be releasing by June, and we're creating actually a master course within our own practice, and we'll share that once that is public. We will, that of course I would love to mentor, the information all to be shared.
Oh, thank you. That sounds fantastic. How would you approach a patient who cannot tolerate any interventions and the symptoms seem to get worse, whatever you introduce? Is that a patient where you just have to go IV, which of course a lot of us here in the UK can't? It's you know, quite tough.
That's a very good question, actually, and quite a few are patients like that and keeps us on our toes. Very important to remember, those patients probably will not tolerate IVs either. But what's something that I learned over the years that we use for our Parkinson patient, pulse electromagnetic field therapies are a very gentle approach, but not all of them. And we definitely are promoting ELI technology, extreme low intensity. There are only few companies have ELI technology. The one that we did research is using that. It's made in Hungary. So we just gently calm their nervous system down, and then we support their lymphatic drainages. We use drainage protocols. And after we use the lymphatic, liver, and the bowel drainage systems in place, then you just actually start opening up, and so they can be more receptive. But never forget, some of these patients have severe PTSD, post-traumatic stress disorder, and then their literally subconscious is very hyperactive. So it's also important to work with their vagal tone and calm down their vagal nervous reactivity. And then we can also use vagal nerve stimulation systems sometimes. I don't have a lot of experience with that, but some of the patients that really swear by it, and they just highly recommend it. We just know a couple of them in my practice. But if the patient is so sick and then not even tolerate water, we have patients on TPN, they're not taking anything by mouth. Those patients definitely need more integrative approach, from hyperbaric oxygen to small amount of the baby doses of IV nutritional therapy, and then also mind-body medicine. Mind-body medicine techniques work, and then I also am trained in the Reiki, and then mind-body medicine exercises, art of healing, and things like that. So there's a lot of things can be used to connect with those patients, understand the blockages.
Very, very integrative. That's fantastic. I know it's already after 7. Do you have time just for another couple of questions?
Sure.
Thank you. And then we'll maybe send you a few others if possible, or maybe have you back again, because there are so many unanswered. This relates to the previous question about sensitivity. If a patient had metronidazole and then very severe adverse effects against it, like dysautonomia, visual floaters, and so on, Would you suggest that they take other antibiotics against Lyme disease or completely avoid them?
Oh, that's a good question. Okay, any azole antibiotics like metronidazole especially, and I try to avoid as much as possible because the way metronidazole works is actively, very strongly damages mitochondria.
Oh.
So then, and metronidazole works the way it kills the organism by really killing the organism mitochondria. So, and recovering from any azole antibiotics, tinidazole, metronidazole, and sometimes hard. So then very important to just kind of not go them as a first line. And then, so we're not having a huge setback so that we can use other things besides metronidazole, use as a cyst buster. And we use a lot of botanical protocols as a cyst buster in our clinic. And before even thinking of metronidazole, unless there's a really bad case of parasitic illness or C. diff, I hardly ever touch metronidazole. That's my, I would have to say, one of the least favorite antibiotic.
Oh, that's very, very interesting. Everyone is saying thank you so much. This was just a really tremendous talk with so much information.
Thank you.
One or two more. This is a rather difficult question. I imagine you can't really touch it in just a few seconds. How would you treat hydrocephalus caused by toxoplasmosis?
Okay, that's actually very, very good
one, isn't it?
That is a very, very good question. So then not only toxoplasmosis, cysticercosis, and then it goes in the lymphatics. Now, since the Nobel Prize, we're all aware there are lymphatics in the brain tissue. And then lymphatics gets blocked from toxoplasmosis and also cysticercosis, which is the pork parasite. So then, and very important these patients to be treated in more like inpatient setting. And they could be very sick in outpatient setting. Often steroids are utilized when the hydrocephalus and the lymphatics are in mold. So that's the only one of the only cases probably I would even think of a touch steroid. But then in my clinical experience, since we do a lot of lymphatic drainage by using IV botanicals, and then like we open the lymphatic pathways by using pulse electronic PEMF, pulse electromagnetic field therapies. When lymphatics move, and then we're not dealing with the aftermath of the die-off, when the cellular crud is killed, wants to come out with lysosome, excessive crud wants to come out of the cell. That gets picked up by the lymphatic system to just drain and to be like the aftermath of the killing can be taken out of the cells. But often with patients with the chronic problems and infection, the lymphatic system is so burdened. And that's another reason in biofilms, there's another reason they don't tolerate just killing by itself. Opening the lymphatic system with the multidisciplinary integrative approach, it's, to me, is monumental. We can't clear that with botanicals by itself either. Anybody who only uses botanicals, they're missing out. And they're getting rid of the smoke, the fire is smoldering. We don't get rid of the full fire without doing this as smoke.
Well, with these kinds of conditions, we do need to work in multidisciplinary teams. And I think that's a lesson that we've very much heard from you as well, that you do that as well if necessary. I mean, you're as a 360 degrees doctor don't necessarily need to, but as naturopaths and nutritional therapists, herbalists and so on, I think we need a doctor on the team as well, really, of your kind. Maybe one last question, and I hope this is a relatively straightforward one. Are floaters in the eyes often Lyme? And perhaps, does it indicate that there is Lyme in the brain and organs as well, if a patient has spirochete form floaters?
Okay, so that's a good one, actually. That's one of my favorite things to talk about.
Okay.
So then patients come with Raynaud's, like the blue hands and feet. Okay, it's a sign of oxidative stress in my integrative training and then knowing my pre-med and pathophysiology. If there's no nitric oxide in the cellular level, there's no oxygen. And then you see this kind of, there's no circulation. there's no nitric oxide, there's no microcirculation. So then, and you have lack of glutathione, and you'll see Raynaud's. Raynaud's is not a disease, is a symptom of a disease. And then that disease causes oxidative stress, but I'll apply the same analogy to eye in a minute. So then basically oxidative stress, lack of glutathione, decreased microcirculation, and then not enough oxygen, we've got blue hands and feet. In the floaters in the eye is also a sign of an oxidative stress.
Mm.
And then that tends to just increase with age. And then any oxidative stress, how many, like the retina has got the highest number of microvascular endings in the body, just like fingers and toes, retina. And since we treated quite a few neurological cases, for their vision to return after neurobartonellosis, and then that means that this microcirculation came back normal. But in terms of seeing the floaters and then contributing that to Lyme by itself would be short-sighted. Yes, Lyme can cause oxidative stress. They may experience more floaters. However, and you have to just think that person under oxidative stress, there are so many other reasons. That's why we use a lot of astaxanthin and quercetin.
A lot of what? Sorry, we didn't hear that word.
Astaxanthin, like astaxanthin. It's one of the strongest antioxidants, like glutathione. I'll send you information.
Yeah.
So then decrease oxidative stress in the microcirculation, and then increase the antioxidants, and then improve the nitric oxide synthesis by giving nitric oxide precursors promoting micronutrients.
Okay. Yeah.
And then all of a sudden the vision comes back, and then people start seeing much clearer, and then their floaters will be less.
Oh, fantastic. Thank you. That's wonderful advice. I'm just wondering naughtily whether it is possible for us to recommend that people read your articles, especially the clinical protocols in them, and then maybe later in the year we can have you back and just have a roundtable session where, perhaps with another doctor as well, naturopath, nutritional therapist, whatever, and of course Kunal and Professor Gilbert, and that we ask a lot more questions around your articles and the wonderful cases. Is that possible?
It is possible, as a matter of fact, and then I will announce here, Dr. Susan Mera, who's a naturopath, and I, we are just joining our forces this year.
No, really?
Yes.
Oh,
so
fantastic.
Just now I had to make a public statement. You made me do it.
Congratulations. That's amazing. Thank you. Well, then Dr. Susan should be with you on that as well. So we look forward to that in the second half of the year. Thank you. There's Dr. Susan.
I'm excited.
Yay. Yeah. Well, I'll just mention a couple of further talks coming up actually very soon, and they're very related to this topic. Professor Craig Shimazaki, who's the CEO of Moleculera that we have heard about today, is going to talk about the gut-brain immune triad, what happens when it breaks down, on the 10th of March. That's another Tuesday at 7 o'clock. And Professor Bransfield is going to talk about infection-associated chronic neuropsychiatric impairments on the 7th of April at 7 o'clock. That's another Tuesday. So we've got some fantastic talks ahead. And just to mention that 1 week after that, Dr. Ozdemir and Professor Bransfield will be in London at the ILADS conference. ILADS stands for the International Lyme and Associated Diseases Society. And for the first time in over a decade, they're holding their conference in London. So please do have a look at it's ILADS, ILADS.org. Maybe you can pop the link in the chat, please, Haley. And otherwise, we'll send that out when we send this out, the recording and the slides to you all. Please do try and come along. And we're so much looking forward to that. There are going to be absolutely fantastic talks there. And then there's the conference that Kunal told us about at the beginning, which is CIP, the Chronic Infections Pathology Conference in Istanbul. Very, very special. Dr. Ozdemir is helping to organize that this year massively. And that's from the 3rd to the 6th of September, I believe. Kunal, is that right?
Yes.
And that will be lots of wonderful speakers. Will it be focusing primarily on Lyme and co-infections, or also include these kinds of conditions that are,
Yeah, well, it's chronic
endemic
infection
Japan span?
pathologies. It's chronic infection pathology. So we do have, or we will have speakers on long COVID and other infection related chronic infection pathologies. Although the theme for the conference this year is from data to diagnosis, because the theme last year was show me the data. So we are moving towards, presenters that have data to also show the roadmap for diagnosis. So that is the theme this year.
Brilliant. Well, maybe again before that, Kunal, you with a little team could hold a round table on the kinds of topics that you'll be covering.
Yeah, sounds good. We also have a workshop this year in SIP. So 3rd is the workshop, 4th, 5th, 6th is the conference. Yeah.
Fantastic. Okay.
Diagnostic workshop for.
We'll be sending out details about that, and obviously covering it in newsletters, e-blasts, and so on. So very, very much looking forward to seeing you, Dr. Ozdemir, in just 2 months, a bit less than 2 months.
In London.
Yes.
Thank you so much.
Thank you very, very much again. Absolutely
so much
brilliant
for having
presentation. Me. Everybody thanks you. And could you please, Hayley, take a copy of both the chat and the Q&A, and we'll use those when we have you in the next time. So thank you very, very much again, everyone, for being here, and good night.
All right.
Thank you so much.
Bye-bye.
Have a great day. Appreciate you.
Mm-hmm.